Okay. So a brief orientation to webinars for people who have not attended before. Due to the number of participants, we have to keep the lines muted. But please feel free to ask questions via the chat function on the webinar control panel. If you have a question about something on a specific page, please note the page number, and then when we take a break for questions, we can scroll back to it. Usually we take a break around the middle of the presentation and then again at the end. However, if there are a number of questions, the presenter today has told me that we can take a break and we can anytime and address those questions. So we want to try and make it as interactive as we possibly can. We currently have about 50 people online right now. And when the webinar ends, you will receive a short survey. If you could please take the time to fill this out. Everyone attending will receive a certificate via email. If people are sharing a computer to view the webinar, please list all of the people requesting a certificate, and they will all be sent as attachments to you in one email. I have been told that you can use these certificates for CPRP certification. And then let me just pull up a couple of slides here, and then we'll transfer it over to you, Christian. So as I said, in regards to the chat function, if you take a look at your screen right now, what you'll see is where the arrow is. If you open that up where it says question and answer, if you just click on that, it will open up the chat box, and then you can just send in a question at any time. And then we'll go to the next page. Sometimes the control panel, people have a difficult time closing the control panel. If you just press right there, it may look a little different on your screen because they've updated the software, but the basic idea is the same. There's a little arrow that's pointing to the right. In this one it shows like 2 or 3 black triangles, but you have a little arrow pointing to the right. Press that, that'll minimize your control panel, and then if you press it again, it'll be pointing to the left, and then that will open up the control panel so you can get to the chat function. Okay, let me switch this over to Christian and make you the presenter. You will need to take that and show your screen, and while you're doing that, I'll do the introduction here. Okay, we can see your screen. If you want to make it full size.
Right.
Okay. All right.
So does that come across okay?
Yep, looks good.
Okay, great.
Okay, so just get my microphones and everything in place here. Christian Huygen is a clinical psychologist. He has served as executive director of Rainbow Heights Club, a groundbreaking, publicly funded psychosocial and support agency specifically serving lesbian, gay, bisexual, and transgender people living with mental illness since its inception in 2002. Rainbow Heights Club now serves 500 members, nearly 90% of whom state they are able to stay free of hospitalization and in the community because of the support that they receive at Rainbow Heights Club. During that time, Christian designed a cultural competency training program on LGBT mental health issues for mainstream care providers, which has now been presented to over 2,000 individuals in over 100 different agencies, universities, hospitals, and clinics. Dr. Huygen has served as provider co-chair of the LGBT Citywide Committee of the Federation of the New York City Department of Health and Mental Hygiene since 2006. He co-chairs the Technical Assistance Committee of the Empire State Pride Agenda's LGBT Health and Human Services Network, and in this capacity, helped to oversee the first ever statewide assessment of the health and human service needs of LGBT New Yorkers. He was recently appointed to the Advisory Committee of the Coalition of Behavioral Health Agencies Center for Rehabilitation and Recovery, as well as the OMH Multicultural Advisory Committee. And in my brief time working with Christian, I just want to say he's been very a great advocate, very assertive, got a lot of energy and enthusiasm around the subject. It's been a pleasure. He's made my job very easy, and I really appreciate that. And with that, I turn it over to you, Christian. Thank you.
Thank you very much, Tony, for that really warm introduction. It's a great honor and a pleasure for me to be here with you today, and I want to thank you all for dialing in. I look forward to speaking to you about how we can welcome not only lesbian, gay, bisexual, and transgender mental health consumers into recovery, but actually all mental health consumers, because I just want to make it clear that that is my big goal, that not only LGBT people could have the respect and the dignity that we all need if we're going to have our mental and emotional well-being, but that all mental health consumers could have that. So, and I really hope that the recommendations that I'm going to be giving you today will help all of your clients, all of your loved ones to have the support and the affirmation that we all need. Just a second, I'm going to... There we go. Okay, now I've watched a number of webinars now, and I'm always wondering, who is this person who is talking to me? So I thought I would start by trying to give you a sense of that, if my slide would move. There we go. So that's me. My name is Christian Huygen. I'm a clinical psychologist. I'm 46 years old. I'm a gay man, and I've been working predominantly with LGBT clients for the past 12 years. And as Tony said, I've done this training or versions of this training many times, and I'm very passionate and happy about having a chance to share some information with you. The other thing I'm always wondering when I watch a webinar is, who does this person think they're talking to? So I wanted to let you know who I think you are. It's my understanding that we have a mixed audience today consisting of care providers, who of course are the VIPs. They're one of the groups of people that I'm hoping will enhance their skill set today and just help them to use the wisdom and the great skills that they already have to serve the broadest range of clients possible. We're also talking to consumers today. I really enjoy working with and collaborating with consumers. The support that you provide to your peers is often more important than the support that mental health professionals provide. And last of all, family members. They're one of my favorite audiences to talk to because they're one of the toughest and most demanding. So I really want to thank you for being here today, and I want to thank you for being there for your loved ones. I want this seminar to be a safe space for you to ask questions. If we're going to talk about sexuality and gender identity and sexual orientation, we need to be able to speak frankly. So please don't worry about using the proper language, the polite language, the politically correct language. Just get your question out so that we can all address it and learn together. Here's what I hope we're going to discuss today. I'm going to talk to you about LGBT issues and exactly what all those letters mean, and talk about some of the particular hurdles and challenges that this population runs into when we try to find affirming and supportive care, because often that's really difficult for us. But I do want to underline a lot of the challenges that LGBT people run into, everybody struggles with when they're trying to bring their sexuality, their sexual relationships, or their relationships into their recovery. Talking to your care providers about all of that stuff is a really big challenge for everybody. I also want to give you some simple recommendations, whether you're a peer, a consumer, a family member, or a care provider, just simple ways that we can all be more effective in helping all mental health consumers talk more openly about their sexuality and their gender identity and any challenges that might be bringing up for them in their recovery. We're going to spend about 10 minutes talking about the whole spectrum of transgender experience, which is kind of a shame. Sometimes I give a whole 90-minute presentation about that, but at least we could get a start in helping people understand something that oftentimes a lot of people have questions about. And as Tony said, a couple times during the presentation, we're going to take a break and have some questions and discussion. Well, I wish we could have discussion. Actually, that's one of my favorite parts about doing live presentations is that back and forth with an audience, but we're going to get as close as we can to that today by using the chat window. I want to tell you something that I am not here to do today. I am not here to tell anybody what to think. Relationships and sexuality and sexual orientation and gender identity, those are things that everybody has a lot of strong opinions about. And I don't want to tell anybody what is the right or wrong thing to think about those things. I just want to give you the tools so that all of us can be more effective, more supportive, and more welcoming to all of the consumers in our lives. Okay, and like I said, my big goal, which I am very happy to reiterate, I am not just here to advocate for the well-being of LGBT mental health consumers. I want everybody in recovery, any kind of recovery, to have their dignity and the respect that they need, regardless of what their sexuality is like, regardless of what their sexual orientation or gender identity is, regardless of whether or not they're interested in sexuality at all. A lot of people are not interested in exploring their sexuality, or not interested in having a relationship with anybody else, and that's fine. People like that deserve just as much respect and dignity and support as all the rest of us. Okay, I would like to tell you a story about a member of Rainbow Heights Club, and this story kind of illuminates why we do the work that we do here at Rainbow Heights Club, and also why I do these trainings. Now, I want to take a break for a second and ask, Tony, am I talking too fast?
Sounds good to me. Audio's
Okay.
very clear, and I think this is a good pace.
All right, thank you very much. I appreciate that. So this story is about a woman named Maria. She's been living with schizoaffective disorder for about 10 years. And Maria is a member of Rainbow Heights Club, and she is a butch Latina lesbian. And what that means is that she's a woman who thinks of herself as a woman, is attracted to other women, and has sexual and romantic relationships with other women. And the way she presents herself, her physical appearance is kind of masculine. She wears her hair in a really meticulous flat-top crew cut. It is much nicer than any flat-top crew cut I have ever had. And she wears the kind of clothes that maybe a male construction worker might wear, like a button-down work shirt and jeans and boots. And I think she looks really great like that. She looks like herself. She looks really confident. She looks comfortable in her own skin. And that's the way she's comfortable presenting herself to the world. So she was in the waiting room of a mental health clinic waiting to see a new therapist for the first time. And while she was sitting in the waiting room, a guy walked into the room, and he looked at her, and he said to the receptionist, "Mira esa puta," which means, look at that pervert, look at that whore, look at that dyke. And then he walked out of the room. And the receptionist laughed, and a couple of people at the other end of the waiting room started whispering amongst themselves. And Maria was not completely shocked that this happened to her, because looking like she does, things like that happen to her frequently, just walking around in New York City. But she was hoping that at least in the waiting room of a new mental health clinic she would be safe. And she wasn't. So her name was called, and she started walking down the hall toward her new therapist's office. And she started wondering to herself, what am I going to be able to talk about with this new therapist? Am I going to be able to talk about what just happened to me in the waiting room? Am I going to be able to talk about the stuff I hear people saying about me or to me several times a week walking around in New York City? Am I going to be able to tell my new therapist about my girlfriend? Am I going to be able to tell him or her about the fighting that we've been getting into lately? So she got to the doorway of her new therapist's office, and she stepped through the door, and there, sitting behind the desk, was the guy who had said, "Mira esa puta." And he did not say, "Oh, I'm so sorry I said that about you." What he said was, "Hi, Maria, I'm your new therapist. Sit down. What's on your mind?" So Maria told me this story, and at this point I said to her, "Maria, did you tell him that you knew what he said about you?" And she said, "No, Christian. I had a lot of stuff on my chest." So the point of my story is that she didn't tell him any of the things that she was hoping to be able to talk about. And she, just like lots of LGBT people, even in their therapist's offices, even when they're talking with their family and their loved ones, sometimes they don't feel comfortable saying the things that would help them most. To talk about what's really bothering them, to talk about ways that you or their therapist or their families could really be helping them. A lot of times we feel like we're just supposed to shut up and be as invisible as possible. So the objective of this whole presentation is that hopefully you will be more like the therapist that Maria was hoping she would meet that day. And luckily she came to us and told us this story, and we were able to refer her to a therapist who did want to hear everything that Maria wanted to say. And as a result, she has never gone back to the hospital, and she got a job, and she has successfully kept it for years. I just want to give you a snapshot of what we do here at Rainbow Heights Club, just so you'll have a picture of where I'm coming from. We provide psychosocial support and advocacy. We've been open for 8 years. We pick up where people's therapists and psychiatrists leave off. We've got a broad range of staff, including psychologists, social workers, consumer providers, student interns, and volunteers. And all of our programming is driven by what consumers want and are interested in, because we don't have any attendance requirements, And we don't have any mandatory groups, so if people are just not interested in a group, they're not going to come. So we're very interested in providing topics and activities that people are going to be interested in. All of our services are provided entirely free of charge. We have funding via contracts with the New York City Department of Health and Mental Hygiene, the New York State Department of Health, a number of foundations, including the H. Van Ameringen Foundation, and a number of donors, and assembly members, state senators, and city council members. And we're very grateful for all of that support because it makes it possible for our consumers to participate in Rainbow Heights Club and also whatever Medicaid-driven services they might be receiving. For instance, day treatment programs in clubhouses, so they don't have to make any either-or decisions about their care. We have a pretty strong track record over the past 8 years. As Tony already said, we've gotten 500 members. About 30 to 50 people come every day. We're open 5 days a week, Monday through Friday, from 12:30 to 8:30. And when people join Rainbow Heights Club, we often see immediate improvements in how committed they are to their care, to being an effective member of their own treatment team. Their self-esteem and their social support rapidly improves, which, of course, if you don't have self-esteem and you feel really isolated, you might not feel motivated to really be engaged in your own treatment. And as a result, nearly 90% of our members say that they're able to stay out of the hospital and in the community because of our support, and that helps save all New York taxpayers millions of dollars every year. What do we do at Rainbow Heights Club? We've got a safe space for socializing. We've got internet access. We've got lots of activity and support groups happening every week. Every day we have dinner together, family style, and consumers can help plan those meals, cook those meals, serve those meals, and clean up after those meals. And it's really wonderful and very powerful to have this simple ritual of coming together as a community and sitting down and all being nourished together and enjoying each other's company. And I really think that especially people with serious and persistent mental illness, they're almost systematically denied experiences like that. So if we can give people back opportunities to come together, work together, and support each other, and experience themselves as being a source of support and help and not just a recipient of support and help, I think that's a very powerful recovery-oriented experience. And we've got lots of venues for consumer feedback, including a community meeting every week and a consumer advisory board meeting that meets every month. Okay, and speaking of snapshots, this is a picture of very happy, excited members and staff and volunteers of Rainbow Heights Club. We were getting ready to participate in the LGBT Pride Parade last June, marching down Fifth Avenue. And it was a wonderful experience. It's our second year that we've done that, and people just love doing that. We had a truck covered with banners and rainbow flags, and people had these big banners that they were carrying that said Rainbow Heights Club, support and advocacy for LGBT people living with mental illness. And it's just very powerful to me that people were excited and proud about owning those multiple identities and marching down the street. It was a wonderful experience to be part of. Okay, so that was my preamble. Let's talk about meeting the needs of LGBT people who are living with mental illness and or substance abuse and or alcoholism and or developmental disability. First of all, how many people are there? How many people are we talking about, Dr. Huygen? I mean, that's a minority within a minority in New York. What, are there like 5? Let's do some math. First of all, I looked at the New York City Community Health Survey, which showed that about 10% of the men in that survey are men who have sex with men. That's what those letters mean. And about 5% of the women in that survey are women who have sex with women. Now, why do we use these fancy, irritating acronyms instead of just saying gay and lesbian? Well, the problem with labels like gay or lesbian is that some people feel comfortable saying, yes, I'm gay, and some people don't feel comfortable with those labels. So MSM and WSW is just a way that researchers try to just talk about what people do, what behaviors people engage in, rather than what labels they apply to themselves. But those figures, 5 to 10%, are similar to the figures that we get in just about every attempt to find out how many people self-identify as gay or lesbian. Now, unfortunately, we don't have any good figures on how many people identify as bisexual or transgender because not enough research has been done. Now, the U.S. Surgeon General says that about 2.6% of adults right now are experiencing a serious mental illness. So I did some math. About 27,300 LGBT adults in New York State are living with serious mental illness right now, and in New York City, about 11,000. Now, in New York City, how many agencies do you think there are that are specifically funded to meet the needs of this particular population? 2. 1, 2. Rainbow Heights Club is one of them, and the other is Center Care Services at the LGBT Center, which is a small mental health clinic that can only provide short-term treatment for psychotherapy and also substance abuse recovery. So those are 2 LGBT agencies, 11,000 people. What does that mean? That means that most of those people in New York City and also statewide are being treated in mainstream care settings. And they should be able to be treated there, and they should be able to be treated well there, which is one of the reasons that we built these Pride trainings. I want you to know that LGBT people experience elevated levels of negative mental health outcomes. In other words, we need your care and support even more than the average person does. In that same community health survey, people said they experienced more poor mental health, more drinking, more drug use, more smoking, and more domestic violence than our heterosexual counterparts do. Actually, in that survey, women in relationships with other women reported 4 times the level of domestic violence that their heterosexual counterparts did. I don't know if they reported more readily or if they experienced more domestic violence, but one thing I can tell you is if you are a gay or lesbian person and you call the police and you say, my boyfriend or girlfriend just beat me up, you will probably not get a very supportive response. So right now, please take out your pen. I want you to write down a resource to rely on in the future. It's avp.org. That's the LGBT Anti-Violence Project. They do a couple of very important things. For one thing, they keep track of how much anti-LGBT violence and assaults happen and where they happen. And another thing that they do is if you are an LGBT person and you experience violence or crime or an assault, they can help you work your way through the police system and the justice system and get the support and the respect that you need. In addition, people also, I wanted to say another resource while you're writing is rainbowheights.org, which is the Rainbow Heights Club website. One of the most important parts of it, in addition to just information about Rainbow Heights Club and our weekly schedule of events, is our list of linkage agreements that we have with other care providers that are LGBT affirming. So there's housing services there, there's AIDS and HIV services there, there's medical health services there. So if you need resources in the LGBT community, that's a good place to go.
Christian, excuse me.
Yes.
Is that that's Rainbow Heights, all one word, .org?
Yes.
Okay. O-R-G.
Thank you. Thank you. Another thing about LGBT people is that we know that across the lifespan they experience an elevated risk for depression, anxiety, and suicidality. And people debate why is that the case. Are LGBT people just more prone to mental illness, or is it stressful and anxiety-provoking to live as a second-class citizen and be systematically deprived of our rights? But that's a philosophical argument that's beyond the scope of what we can really settle today. I have some good news for you, though. You don't have to be LGBT, research shows, to be effective with LGBT clients. You just need some basic information, like what I'm going to be providing for you today, and a willingness to take the skills and the wisdom that you already have to benefit the broadest possible range of people that you can. Okay, I have been throwing these terms around and I haven't defined them, so let me catch up with myself and do that now. A lesbian woman or a gay man is somebody who is attracted to and probably has relationships with other people of their own sex. And I just want to make the point that that is not just physical and sexual attraction. That's emotional attraction, intellectual attraction, spiritual attraction, the butterflies in your stomach, all of those wonderful feelings of just being attracted to somebody. And all of those feelings are the same as the feelings that anybody else feels. Falling in love feels the same. Having a crush feels the same. Being rejected feels the same. The pain of losing a long-term partner feels the same. So once you get over the fact that maybe that person's object choice is not what yours might be, all of your know-how, all of your empathy, all of your wisdom, all of the good advice that you'd be able to give, that's all still going to work with a lesbian or gay or bisexual person. A bisexual person is somebody who might be attracted to men and or women and might have relationships with men and or women. And that sounds really great. In fact, Woody Allen used to say a bisexual person has double the chances of a date on a Saturday night. But bisexual people face really difficult challenges that even I, as a relatively happy, healthy, well-adjusted gay man, don't have to put up with. For one thing, if I want to go to a gay neighborhood, go to a gay restaurant, and then a gay bar, and then a gay nightclub, and then the next day go on a gay cruise line for a while, and then when I get back, go to a whole series of gay 12-step groups to get over all of that experience, I could do that. All of that exists for gay and lesbian people. That doesn't exist for bisexual people. So if you say, oh, I want to go be bisexual, I just don't know where you go. That sounds trivial, but it's a really big deal. And another big problem that people who self-identify as bisexual face is that almost always, when they say to somebody, I'm bisexual, that person will say, no, you're not. If that person's straight, they'll probably say, no, you're not, you're straight, get over it. And if that person is gay or lesbian, they'll probably say, no, you're not, you're gay, get over it. So it's just really difficult for bisexual people to have what I consider to be a basic aspect of human dignity, which is the ability to just say who you are and have people believe you. And speaking of not having that basic human dignity and respect, transgender people have a very difficult time being acknowledged or taken seriously. Transgender is a very broad umbrella term for a broad range of experiences and maybe also the expression of that experience of having a gender identity, a very profound subjective sense of who you are gender-wise that doesn't necessarily match up with whatever box the doctor checked on the day that you were born. And for some of us, it's hard for us to imagine that kind of experience. But, I was thinking about this. I don't think any of us have a very accurate idea of ourselves. I'm 46, but I pretty much feel the same way I did when I was 22. And physically, I don't really resemble Superman, but sometimes I imagine that I do. And I think all of us do this. We have a sort of subjective idea of ourselves that isn't really necessarily very closely based on our physical body. So I don't know. I don't know if it's helpful to extend that thinking into gender, but we'll talk about that in some more detail a little later. Now, why is sexual orientation and gender identity relevant to recovery? Well, for one thing, I actually think that discussions of recovery and client-centered goals have put a lot of this on the table. I mean, now we didn't used to think that it was normal for people in the mental health system to be wanting these things that everybody wants, if they want them, a home and a meaningful work and a date on a Saturday night. If you want a date on a Saturday night. Not everybody does, and you certainly don't have to be a normal and healthy person. But if you do, now that we know that clients should be able to define their own recovery goals, people are talking about a much broader range of goals, and because there's that normal, beautiful human variation in sexuality and in gender identity, people are saying to their care providers in their long-term psychiatric residences, I want you to help me find a same-sex partner. I'm lonely, I want to find a guy to date, and I want to settle down. And for a lot of care providers, this is kind of a new experience and not a very comfortable one. A lot of care providers did not get into this field thinking that they would be helping people to really actualize their sexuality and their normal wishes for companionship and intimacy. And if you add to that discomfort, the discomfort of possibly dealing with clients who are lesbian or gay or bisexual or transgender, it can be pretty uncomfortable for care providers. A lot of them, nobody likes to feel stupid or unprepared in their work. And I think that sometimes, unfortunately, people are finding themselves feeling that way. And sometimes they react to finding themselves in this position by saying to the client who's bringing this up, by saying to the client, that was inappropriate, you shouldn't ask me for things like that. When really it would be a lot healthier and a lot more human and a lot more compassionate if care providers could just say, you know what, That's a new idea for me, but I'm going to try to help you or figure out if I can try to help you. But even if I can't help you with that, I can totally understand that you want to find somebody to date. That is a normal thing to want. Does that make sense? I mean, like the reason that I said I don't know if I can help you is that maybe you're a counselor in a residence, and maybe none of your clients are allowed to have sexual relationships in that residence. And I think it's important to underline, well, you know what? I might like to be able to help you find somebody to date, but as you know, none of our clients are allowed to have sexual relationships here. We might be able to talk about where you might be able to go to meet other people, but I don't know if I'm going to be able to help you find somebody to date. So just treating LGBT clients the same way that you treat all your other clients is a really important rule of thumb and a guideline to try to follow. Also, it's really important to help people talk about their sexual orientation and their gender identity because frequently people might have a lot of internal conflicts around that, and they might have a lot of conflicts between themselves and other people around that. So both of these things can make people vulnerable to relapse, to wanting to self-medicate, to picking up, to possibly heading back to the hospital. And if people don't feel like they can talk safely about these things, then that threat to their recovery is just going to stay with them. And conversely, if we can help people talk about these things, then that threat to their recovery is going to be very much diminished. Okay, I'm a clinical psychologist. What does the APA say about same-sex sexual orientation? For one thing, it's not a choice. I don't think we choose our sexual orientations. I think that they choose us. And actually, lots of LGBT people try not to become what they feel themselves becoming. They try to push their feelings of attraction onto other people that they know will be more acceptable to society, and it doesn't work, and it's very painful for people who are trying to do that. For me, I remember the day that I just decided to accept myself as I was and try to be the best version of myself that I could be was a very important turning point in my life, and I think for a lot of LGBT people, it's like that. So since it's not a choice, it's really not appropriate to talk about this as a lifestyle. It's not like something we decided to do because it seemed cool. It's determined by a lot of factors, usually by a very early age. It's not just genetics. It's not just the hormones that you were exposed to in your mother's womb. It's not just something your mother did or didn't say to you. It's a lot of those things, plus we really don't know what. Even in identical twin pairs, only 44% of the time do they have the same sexual orientation. So it's not just a gene that you could try to control. And same-sex sexual orientation is not considered to be an illness or an emotional problem in itself anymore, although you might know that up until 1973 it was listed in the DSM as a mental illness. And some really interesting things were done to people to try to cure this so-called mental illness, including painful electric shock, and sometimes even castration and lobotomy. And people today know, sitting in their therapist's office wondering, should I tell this person that I'm a lesbian? They know that the mental health industry has treated people in this abusive way in the past, so naturally they're kind of shy about disclosing their LGBT status to their care providers and loved ones. Sexual orientation is different from sexual behavior. What do I mean by that? I mean two different things. For one thing, just having had same-sex sexual behavior doesn't necessarily make you gay. There's lots of contexts where people have a limited range of options, for instance, prison or the military or other places where you just don't have the range of choices that you might have in another context. And people are human beings, and sometimes they do what is available to them to do, and that doesn't necessarily mean that they're gay or lesbian. Your sexual orientation, your sexual identity is about what does your idea of your future happiness look like. And whatever that is, you can still have that, regardless of what you've done in the past and regardless of what might have been done to you. I also want to point out that sometimes if people need food or shelter or safety or drugs or protection, they might trade sex to get those things. But again, that doesn't necessarily make them gay or lesbian or heterosexual if they were trading heterosexual sex to get those things. Your sexual identity, it's up to you to decide. It's up to you to decide what your happiness looks like. And I am very serious about your happiness, so I hope you are too. There's another way that sexual orientation is different from sexual behavior. There's a lot of LGBT people who don't have sexual relationships. Over half of the people at Rainbow Heights Club are not seeking and are not having sexual intimate relationships with other people. Why? A lot of them say that with their psychiatric symptoms, it's too confusing and uncomfortable to be that close to another person. But it is still very important to their self-esteem and their recovery to be acknowledged and affirmed as LGBT people. Also, I would never say, and I would never want a care provider to say to an LGBT person or to anybody, well, look, you're having these feelings of attraction, therefore you should do X or Y or Z about them. That is totally not up to me. That is the dignity and the freedom of the client. And some people decide not to have relationships, and that's their choice, and I would never argue with that. Also, I just want to underscore that according to the American Psychological Association, sexual orientation can't be changed by therapy. You might have heard of so-called reparative therapies, which try to propose that they could make somebody stop being gay. And it might or might not shock you to know that a lot of the same techniques are used that used to be used on gay and lesbian people before 1973. For instance, painful electric shocks, or emetics, which is a substance that you ask the client to drink and then they vomit. So hopefully they're going to learn that it's bad. It's bad to be a gay or lesbian person. I think that's just abuse, and so does the APA. I think it's never going to change somebody's sexual orientation. It's not ethical. It's not treatment, and they're just going to feel worse about themselves afterward. So on the other hand, I want to point out people can relatively easily decide whether or not they're going to engage in a given behavior, and that's fine. That's up to them. But it's very, very difficult to say, I don't want to have these feelings anymore. I'll tell you something personal about myself. I have very strong feelings of attraction toward chocolate. If you put a chocolate bar on the table in front of me, I would probably be very attracted to it, but I could easily say to myself, you know, I'm going to decide not to eat that chocolate bar. That's easy. And I can still have my dignity and my identity as a person and make that choice. But if I say to myself, I don't want to have those feelings of attraction toward that chocolate bar anymore, I just don't know what you would have to do to my brain. I think we would have to pour Drano into my head to make me stop feeling attracted toward that chocolate bar. All right, I've beaten that point into the ground. So I just want to tell everybody, you might be having questions. In about 10 more minutes, I'm going to sort of wind up this list of challenges that people face and make some recommendations for how to address those challenges. And maybe that would be a good point for us to pause for questions. Does that sound okay?
Sounds good.
Okay. So what is it like to be a person living with all this stuff? For one thing, we feel a lot of stigma. LGBT is stigmatizing in our society, and mental health status is stigmatizing in our society. Those are things that make people feel ashamed and like they should try to be invisible. People might have other layers of stigma on them, too. They might be living with racial or ethnic prejudice. They might be living with physical disability. They might be living with low socioeconomic status. Lots of burdens of shame that people could be carrying around. And all of those things make people want to hide. So often LGBT people in mainstream mental health settings are going to try to hide their LGBT status. And often in the LGBT community, people are going to try to hide their mental health status. And that's very painful because I think the only way that we can heal and recover as human beings is just to be able to own the entirety of our human experience and be able to express it to each other. So people need places where they don't have to hide. Rainbow Heights Club was designed to be a place like that. I hope that the offices of the care providers on the call today are going to be like that. I hope the families of everybody else are going to be places like that. We also live with invisibility. Like I said, there's lots of good reasons why people can be shy about disclosing to their therapists or their families. I've talked to lots of mental health care providers who have hundreds of clients, and they don't think that any of them are LGBT. And what that says to me is that those care providers are not providing an environment where their LGBT clients are comfortable disclosing to them. We already talked about a couple of these issues, but gender identity disorder is a diagnosis that any transgender person who's seeking any kind of treatment would have to accept. And that's sort of, a label of mental illness. And for some people, that's no big deal. They'll say, oh, just write whatever you want to on your piece of paper. As long as you can keep taking care of me, that's all I care about. But for some people, this is a really big insult that they can't abide. So just check in with people about what they're feeling. Also, our clients know that pervasive homophobia is a part of our culture that we all grew up with, just like racism and sexism and misogyny. When I was a kid, the worst thing you could call somebody on the playground was faggot or dyke, and I don't think that has changed at all. So unless we take the first step and let our clients and our loved ones know that we want to affirm them and support them regardless of their sexuality, their sexual orientation, their gender identity, they're probably going to assume that we don't want to be supportive and affirming. Because clients and loved ones are very afraid of being rejected by you. They need you. They will do anything to keep your support. They will even keep secret from you the things that if you knew about them, you could help them the most, just like Maria did with her first therapist. We might also sometimes we're the ones who are sending subtle signals that we don't even know that we're sending that inhibit people and make it harder for them to talk about LGBT experiences or identities. For instance, in a lot of clinics and mental health settings, a standard intake question about relationships is, if you're talking to a guy, you might say, are you married or do you have a girlfriend? And if you asked me that question, I would just say no. But if I said that to you, I wouldn't be telling you what you would need to know about me to really understand me and understand my situation. It's very easy to just say, are you in a relationship right now? What kind of people are you usually in relationships with? That's a way of asking a question that opens a door, and it's not going to freak out your mainstream clients, and it's just going to enable you to have more open-ended conversations. Another way that you can take the first step to let LGBT clients know that you would like to affirm them is if you just have a little brochure of an LGBT mental health agency like Rainbow Heights Club or a little rainbow sticker on your front door. People are going to see that, because LGBT people are very sensitive about looking for clues about who's going to be safe to disclose to. Why? Because almost all of them have lost a friendship or the support or an acceptance of a family member or the support or an acceptance of an entire family or maybe even an entire religious community over disclosing around this issue. So people are very careful. And they scan very carefully, and even a little clue like that, just a brochure stuck to your bulletin board. Maybe if you've got a bunch of magazines in your waiting room area, you could have one or two gay or lesbian magazines mixed in there. It sort of makes people feel like they're allowed to exist in your clinic. So these obstacles, I already talked about stigma and invisibility. I just want to briefly say that sometimes our care providers may feel like they don't know how to support us. If they think that we're the first LGBT person they've ever talked to, they may have lots of skills and wisdom and know-how, but they may feel like they don't know how to apply it to us. So sometimes just thinking through the fact that some of our clients and some of our loved ones could be LGBT might enable us to unlock some of that potential. Another really big obstacle is that we may not be sure we know how to support and accept ourselves. Some of us really struggle with accepting the fact that we're LGBT. I know a lot of people who hate themselves. Unfortunately, people hear a lot of things from their therapists and care providers that make it even harder to accept themselves. One member of Rainbow Heights Club told me that his therapist once said to him, "You are going to hell and I can't help you." And it might not surprise you to learn that 1 week after that, he made a very serious suicide attempt, and he nearly died. So the things that therapists say are very powerful, and sometimes we really need to, as the care providers or loved ones of LGBT people, we really need to develop a conviction, a very deep-seated, yes? I'm sorry, was that Tony?
No.
Okay, I'll keep going. We need to develop a very deep-seated conviction that LGBT people are human beings and that they deserve dignity and respect. And the reason we need to hold that belief is often the LGBT consumer sitting in front of us does not believe that. So you might be the first person who has ever held the idea that that person, that LGBT mental health consumer in front of you who needs support and help, is a human being with dignity and deserving of respect and deserving of supportive care, someone with creativity, someone with good intuition, someone with wisdom. Sometimes we need to recognize people as being that because they're not able to recognize that potential in themselves. And often, if we're going to keep our recovery, we have to tell the truth. We have to tell our stories, our real stories, our complete stories, including all of the things that challenge us. And for many of us, our sexuality and our gender identity is in that category. So we need to find 12-step groups, support groups, peer support groups of people who are willing to support us in that way. Because often your sexuality and your gender identity can have a lot to do with why you're picking up substances, where and how you're doing that, and what impact that's going to have on you. For instance, if I have a lot of internalized homophobia, a lot of internalized self-hatred because I'm a gay man, I might take crystal meth to try to have a short vacation from that. I might take crystal meth and then go to a sex party and then for 8 hours have unprotected sex because of the drug is very uninhibiting with a dozen people, and that could put me at a lot of risk for HIV exposure. So if I am going to really talk to my care providers and they're going to be able to help me, and if I'm going to talk to my peers and if they're going to be able to help support me in my recovery, I would have to have care providers and peers who are willing and able to hear all the facets of that story so that I could really get better and get out of that situation. Okay. For a long time, I have been talking about all the challenges that LGBT people face, and here's how we can respond. One thing is we can use inclusive language. Like I told you, we can ask people about relationships instead of boyfriends and girlfriends and husbands and wives. It's also very important when any client makes a disclosure around their sexuality or their gender identity to say, I'm glad you told me that. It's very reassuring. For instance, if you asked me about my relationships and I said, well, there's this great guy that I've been seeing for almost 3 years now, it would be very important. I'm going to be very interested in how you respond to that if you're my therapist. And it would really help me if you said, I'm glad you told me that. Where did you meet him? What's he like? That sounds really simple. But those simple questions convey a lot of information. That lets me know that this is a normal thing for me to talk about with you, that you think it's real, that you think it's important, and that you want to hear more. And all of those messages are going to help me have a much stronger treatment alliance with you. Another important thing is to accept the person's definition of the problem. For instance, if you were my therapist and I came in and I said to you, I'm a gay man, that's not a problem. I have a boyfriend, that's not a problem. The problem I want help with is that when we both drink too much, we start hitting each other. Can you help me with that? A good way to respond would be, okay, well, do you want help with the drinking part or the hitting part or both? Okay, yes, we can work together on that. That would be a good first step. But what a lot of care providers tend to do is they say, this gay thing, when did that start? How do you know? Have you ever had a relationship with a woman? And right there, it's sort of like you're disagreeing with me. I told you that my being gay and dating a guy was not a problem for me, and you're sort of saying that you think that it is a problem. So right there, if we start off on that footing, I'm going to feel like we don't have a working treatment alliance. And providing a safe and affirming environment is kind of what we've been talking about in different ways all through this presentation. But just the last thing that's very powerful for any client, but especially an LGBT client or loved one, is to say empathic things like, oh, I'm so happy for you. I bet that was a great experience. Or, ow, I bet that really hurt. I'm sorry to hear that. Or if it's true, it's very powerful to say, you know what, in your situation, I bet I would feel exactly the same way. If that is true, that would be a great gift to give to any client or loved one, and it's probably beyond most LGBT people's wildest dreams to have people putting themselves in their shoes emotionally in that way. So that's a really powerful thing that you can do. I'm going to just give you one simple rule of thumb when you're thinking about how to talk to an LGBT client or loved one. Would you say that to a non-LGBT person? I mean, those questions that I was asking about, like this gay thing, how do you know, when did it start? If you flip that around and imagine asking a straight client, this heterosexuality thing, how do you know? When did you first become a heterosexual person? You can sort of see the existential absurdity and kind of the cruelty in those questions. Nobody would be able to answer that question. So you probably wouldn't say it to a non-LGBT person, so it would probably be a good idea not to say it to an LGBT person. And similarly, with transgender people, a lot of people assume that it's a good way to show openness and get to know a transgender person by saying, oh, that's so interesting. Have you had the surgery yet? And so you're kind of zooming in and asking people about their genitalia, like when you're first getting to know them. And I don't think any of us would ask a non-transgender person, oh, it's so nice to meet you. Are you happy with your genitals? Have you ever surgically altered them? What are they like? That it would just be really offensive, and many trans people are very offended in a similar way when we sort of try to show that we are open to hearing about their issues, and we do it in that sort of clumsy way. So I just want to say I'm really glad that you're here on this call, because this is a really challenging issue for everybody. Talking about mental health and mental illness, I think we're all on a continuum there. I think all of us experience small or large glimpses of what it's like to have every kind of psychiatric symptom. I know that when I miss the subway by 3 seconds, I imagine for about 15 or 20 minutes that the entire MTA system was built just to infuriate me. But luckily that feeling passes after a while. And similarly, I think that we're all on a continuum of sexualities. I do not mean that everybody's bisexual. I do not mean that you should alter your sexual behavior in any way. But we've got trillions of neurons in our brains, and sometimes one of them just fires at random when we're looking at somebody who we don't usually think as being in the categories of people that we're allowed to be attracted to. And sometimes that little neuron fires and we say, wow. And then sometimes we catch ourselves and we panic. And we think, oh, what's happening here? I just had a fraction of a second of attraction toward somebody I don't think I'm supposed to be attracted to, and then we have an identity crisis. But we could just skip the identity crisis and say, oh, I'm a human being. I just had a human moment. A neuron just fired in my head. You could be kind to yourself. You could be hospitable toward yourself. And if we practice that toward ourselves, we're probably going to be a little bit better at being kind and hospitable to the other people in our lives. And similarly, just about all of us know that we don't really resemble the little cardboard cutout stick figures on men's and women's bathroom doors. We've all got sort of little quirky aspects of our personality, or things that we're good at, or things that we enjoy, that maybe they're masculine or maybe they're feminine, but they make us who we are and they make us unique. Like, for instance, I'm a pretty good cook. Some people would think that that's a feminine thing. Some people would get very offended that I said that some people would think that was a feminine thing. I like taking care of children. I think all of us in this field like taking care of other people's emotions. Some people think of that as being a sort of a feminine or a nurturing thing. It's something that personally I'm very proud of. So if we can, again, be hospitable toward and value and cherish our own uniqueness, I think we're going to be able to be hospitable toward and cherish the uniqueness of the person sitting across from us. But this takes stepping out of your own comfort zone. Being here today, I know, probably has taken all of us out of our own comfort zones. Every time I do this presentation, it takes me out of my comfort zone, but I still think it's a really important and valuable thing to do. And with that, we could take some questions.
Okay, great. So I just sent out a note to everyone that we were going to be taking questions. So if you have any, please send them in via the chat function, and please let me know if I'm dropping out with the audio, because sometimes I step back a little bit and get a little animated when I'm speaking. All Okay, first question. What are some thoughts to consider when welcoming LGBT mental health consumers who may also be stigmatized because of race?
Oh, that's a really good one. Okay. Well, if I was talking to the person who asked that question, I would ask if they could be any more specific. But I do want to say, it's much harder. It's much harder for people of color often to access LGBT supportive mental health services if they're available. It's much harder for people of color to sometimes, depending, but it can be, to openly acknowledge an LGBT identity because what people often say is, I'm already in a marginalized and oppressed community, and you want me to add more? The mainstream non-people of color already look at us with stigma and prejudice, and you want me to add more? You want me to be in a subpopulation instead of just a subpopulation? It's very difficult. It's very difficult. So I think trying to meet people on their own terms, I'm just going to imagine that it's possible for you to get some kind of focus group or input from at least some members of the community that you're trying to reach, and ask them what services would they be open to and how would they like them to be labeled. Because I know that Rainbow Heights Club, I mean, we don't have a rainbow flag on our front door, and we don't have any kind of a sign on the front of our building because we want to sort of fly under the radar in our neighborhood in downtown Brooklyn. But we do call ourselves an agency that serves lesbian, gay, bisexual, and transgender people. And I know that just because we're labeled in that way, some people might feel like, well, we're not, that's not for me, and I'm not going there. You might want to code something as, we're going to set up a support group for people who are in the life and going through some changes. We're going to set up a support group for people who are in the life and going through some changes. That might sound a lot more welcoming to people. I'll give you an example of that doesn't have to do with race, but labeling is very important at Rainbow Heights Club and everywhere. One of our therapists said, would you guys like me to run a psychotherapy group for you? And they said no. And so the therapist said, how about if we had a group where we could talk about our thoughts and feelings? And everybody said, well, that sounds great. And so she said, well, shall we call it Thoughts and Feelings Group? And they said, yes. So it's the exact same thing, but just the way that it's labeled is very important. So trying to meet people where they are and not insisting that they label themselves and not insisting that they do something that they're not willing to do before they can get in the door. Just trying to be more open. Another thing, I just want to make one more comment on that. Let's say you're running a mainstream treatment program and you want to make more room for people to be able to talk about their sexuality. You could do two different things. You might have an LGBT support group, but that can be challenging. Like, let's say you're running a mainstream day treatment program and you say, okay, it's 3 o'clock on Tuesday. The LGBT support group is starting now. Would all the lesbian, gay, bisexual, and transgender people please go into this room right here? I'm sort of making a joke of it, but it could be really awkward and uncomfortable for people to do that. Plan B would be, we're going to have a group to talk about sexuality if people want to participate. Everybody's welcome, but I just want you to know that we're going to be talking about the full range of sexuality and gender identity, and we're going to be respectful and kind toward each other. So if you want to come to the group, you're welcome. That might work better in some settings. Okay, that's the end of my answer.
Well, you may have answered some of the other questions, but in that answer. So let me jump to a couple more here. So as a provider, how can I advocate for a more welcoming How can I advocate for a more welcoming environment in my clinic? As a gay male who is used to being in very open and affirming work environments, it happens the clinic I work in now does not seem to acknowledge LGBT at all. So he's asking, what are some of the strategies?
Okay, that's another great question. Yeah. I think a lot of people find themselves in that position. For one thing, try to find out, go to the highest level that you can and try to find out if your clinic or the system or hospital system that your clinic is a part of has a policy about being inclusive toward and respectful of people regardless of their sexual orientation or gender identity. And if they do, then start out diplomatically, but maybe meet with the director or the team leader of your clinic and say, I noticed that our whole psychiatric center system has a mandate to provide affirming care to LGBT people. I don't really see that happening in this clinic right now. I'd be happy to be on a task force to help think of ways that we could do better on that. And at least see that way that mandate is coming from the high. You want to get a mandate that's coming from the highest possible point in the organization. And I will just give you a preview. JCO, the Joint Accreditation Commission, that decides whether or not a given hospital or treatment center is fit to receive Medicaid payments, is going to take on or has already implemented pretty stringent demands that LGBT people be treated affirmatively and effectively. So do some Googling, do your research, present yourself as somebody who wants to be part of the solution, and you could have some good results. But also when you need to know what the policy is, so that if something happens in front of you, let's say you're just in a support group and a client calls another client a faggot. If you know that your clinic or your whole treatment system doesn't accept any kind of verbal abuse, including verbal abuse or discrimination based on sexual orientation and gender identity, you have the ability to say, we don't talk to each other that way here. It's against the rules of this whole hospital system. If you don't have that policy in place, all you can really do is say, you're not being nice. So it's much better to know what the policies are, and it's much better to leverage those policies to make the changes that you want to see.
Good. That makes sense. Let's see. Next question. Do you have any advice on working with preteens or teens who are questioning their sexual identity?
Preteens or teens who are questioning their sexual identity. The first thing that I want to say is that I only work with adults, and I know that adolescents and teens and preteens have this world of other issues that I just lack expertise in to address directly, like relating to their families and relating to their school systems. However, within New York City, there's a lot of agencies that you could turn to for help. One is the Hetrick Martin Institute, which I believe is just hmi.org. And they also run Harvey Milk High School, which is for LGBT teenagers who were not able to successfully participate in mainstream high school settings, and they can still finish their high school training that way. There's also Youth Enrichment Services at the LGBT Center. The short version of that is YES. If you go to gaycenter.org, you can find out more about that. There's also an organization called The Door. I don't know what their URL is, but I think they're listed on our linkage agreement list on rainbowheights.org. So these are a bunch of services that are effectively meeting the needs of LGBT youth, at least in New York City. But I'm sure that if you call them, they can either give you advice or refer you to other local sources.
Great. And then people are asking if the slides will be available after the webinar, and yes, we will send that out. We've also had a number of requests for the different websites, so what we'll do is in that email to everyone who registered, we will send an email out to everyone that has all of those links that we're discussing today.
Yes.
Let's see. Do you have any suggestions on how to gain a therapeutic relationship with an LGBT individual with mental illness who doesn't acknowledge either aspect?
Okay. You might not be able to, and that might be okay. That I want to say that this is going to be a little bit tangential, but you can't. So somebody doesn't have the insight. Okay, again, I'm not talking to the person who wrote the question. I'm going to assume this means that somebody doesn't have the insight or the ego strength to be able to tolerate defining themselves as either a person who is LGBT or a person who's living with a serious mental illness. It might be not helpful to demand or continually ask or continually wish that the person would embrace these facets of themselves. Sometimes we can develop our own idea of what success looks like to a person. We might get this sort of client. I mean, maybe Maria with her schizoaffective disorder and her difficult relationship with her girlfriend. Maybe she comes in and we say to ourselves, "Oh, I know where I want Maria to be a year from now. I want her to be marching down Fifth Avenue in the LGBT Pride Parade." And maybe that's not what she wants at all. And I know a lot of people who say, I would love to march in the Pride Parade. I know a lot of people who say, I would rather die than march in the Pride Parade. But what is successful for all those people is that they are the ones who are deciding whether they want to do it or not. A lot of people might feel a lot of power and empowerment in deciding who they are not going to disclose their sexual identity to in their lives. And maybe that's the helpful thing for them. You might ask this client, so about, the different things that we've been talking about here today, I'm not going to be able to frame this correctly, and probably because I don't know the person involved, but what does success look like for you? How do you want this to turn out? How would you like to be able to manage this in your life? How do you want to label this? Who do you want to disclose it to? And how do you want to take care of it, if at all? It's hard for me to be more specific about that. But just as mental illness and mental health and recovery can mean so many different things to so many different people, it's the same thing with LGBT. Imagining that, your client is going to, 3 years from now, be happily pushing a stroller down Fifth Avenue in the, gay parents contingent of the LGBT parade might be the opposite of what they would want. But, that it's about what their goals are.
Yeah, if you don't mind my just adding to that, I would just, if I was the clinician, I would just avoid the power struggle altogether and just try to work with the person on other things that they're interested in and engage in that way, rather than persist in this in trying to present this issue that doesn't appear to be an issue for that person at this time. That would be my thoughts around that. Next question. How can a counselor approach a person identifying as heterosexual who admits to bi-curiosity but feels unable to explore these inclinations because of their sense of safety within the approval of the community as straight men?
Okay. I think, again, saying, I'm very glad that you are comfortable in telling me about these different feelings that you have. I'm not sure if you've thought about what you do or don't want to do about them. How would you like this to work out? Again, Tony, you might have better phrases at the tip of your tongue for just asking the client what are their goals. Does it help that I know and I accept you as a person who has some curiosity about his sexuality? Are there any ways that you would like to explore? Do you want more information about safe places to go, or is it just something that you want to keep as part of your private life?
Yeah, that sounds very reasonable.
I mean, I don't know.
It is a little hard to give, feedback on very specific types of cases.
Yeah, it's difficult. I don't know if, I know that some people are sort of afraid of internet dating sites, and it depends on the level of insight and judgment of your client. It also depends on the level of their ability to access the internet in a place that's going to be private, confidential, and safe for them. But for a lot of people, exploring internet dating sites or even sex sites can be a way to sort of explore or play with sexual identity, but it's important to do that in a way that's safe. In other words, not giving your personal address or your phone number to people over the internet, being very careful about who, if anybody, you meet in person, meeting that person in a public place. But what I was more thinking about was just 10 steps back from even reaching out and actually even chatting with or emailing somebody, just being able to sort of look around and see how other people are exploring their sexuality in cyberspace. For some people, it could be really helpful. For some people, it might be kind of difficult and sort of courting almost an internet addiction So that's up to you whether you want to try to propose that. But for many people, that really is how they explore their identity. I did a study of LGBT teenagers 10 years ago, and a lot of them did a lot of their identity exploration and friendship and social support developments through AOL, which was very striking to me. That's the end of my answer. I wanted to say I would love to be able to talk for about 10 minutes about transgender issues and have about 5 minutes to make some closing comments.
Okay.
I don't know if we can fit that all in. Do you have another high priority question now?
Yeah, I'm trying to group them. So I think we answered a couple of questions with that last with that last answer. Let me throw one more out there for right now, and then see where we're at later. Because again, it is very difficult to sort of do therapy by proxy, you know, and although I know people have some very specific examples that they're looking for help with, I think just in general, I think you gave some very good general ideas about just being open, keeping things in a safe place, and engaging people, you know, where they're at, and letting people sort of travel down the path on their own. And if people are not willing, you know, people are not ready to explore, like this last question around bisexuality, because they prefer the safety and security of the straight world. I'm paraphrasing, but you know, then that's their journey. I mean, just maintaining an openness to whenever you're ready, it's okay, and you're safe here to talk about that, and we'll find what's available out there together. You know, I think just being very general like that, and those general strategies will lead to are applicable to all of these specific cases that people are presenting. There is one, though, that I think is important to bring up. Do you think it's important for a therapist to disclose his or her sexual orientation identity to an LGBT consumer if the consumer asks?
That's a great question. I mean, of course, you might want to try to unpack, well, what would that mean to you if I were or were not gay? And also, there's two things that I want to warn against. One undesirable outcome is that a gay therapist decides, over-identifies with their LGBT clients and thinks that, oh, whatever you're experiencing, I know exactly what you're experiencing, and I'll tell you what I did, because you know, any of us who've had either like a trauma history and then we're working with a traumatized client, a certain sexuality and then we're working with that kind of client, we might over-assume that their experience is just like ours. So we actually kind of want to take a step back and remind ourselves that there could be a lot of differences between that client's experience and your own experience. Sometimes clients find themselves in the position of assuming that a heterosexual therapist is gay, and then sort of the client is over-identifying and over-assuming about the therapist, and it can be kind of awkward if you get to a point where the therapist says, well, actually, no, and the client is feeling like, oh, well, I've been having this relationship with this imaginary person for years now. So some people might prefer, it goes a lot to two things. What is the style that you prefer? Do you prefer to be more disclosing and more sort of real as a human being, or do you prefer to be more of a blank slate? And also, what's the policy of your clinic? Many clinics have a slant toward either being very reserved or very forthcoming around their human individuality. But if I were to disclose, I mean, the Rainbow Heights Club is a psychosocial club, so everybody that works here is very open about whatever their sexual orientation and gender identity is, partly because we're role modeling for people that it's possible to do that. But that's very different from the places where a lot of other people work.
There's one more question that just came up that I would really like to throw out there, and then we'll move on to where someone was asking about transgender population. How would you address and raise awareness with an individual who is engaging in risky sexual practices, seems confused with his identity and receiving religious pressure from his family, presumably, you know, in the form of that this is sinful behavior, is my guess. So this sounds like something that is fairly generalizable.
What is the last part?
Around receiving religious pressure from his family. This example here is, although it's a specific example around a person, I think it's fairly generalizable. I think there is a lot of stuff going on with family and religion for folks.
Yeah, that's common. I would say, because we have led, I have taught safer sex education groups that didn't just talk about how to put on a condom, but in 10 sessions, talking in detail about what is your own personal set of safer sex rules and how are you going to negotiate with another person around protecting yourself and protecting each other, and what activities you're going to engage in and what activities you're not going to engage in. So I know that when people have less shame and more self-acceptance, they are more able to make rational, thoughtful, responsible decisions around their own sexual safety and other people's sexual safety. And conversely, and this example shows us this in a very powerful way, when people are ashamed and conflicted, they're much more likely to cope with the situation by maybe getting really drunk and then making some reckless decisions. Right. And so you might, I'm imagining trying to strike a middle ground, like, first of all, I don't know if the person himself, I'm just going to pretend it's a him, if the person himself has a religious point of view or a spiritual point of view, I would ask him to articulate that and work from there. And even if there's some parts that he's not sure about, like, I'm just going to imagine, well, I feel these feelings and I don't know if God is wanting me to explore these feelings or not wanting me to explore these feelings. I would say, well, either way, I'm pretty sure that God wants you to be safe and take care of yourself and take care of other people. So while you're figuring out the other stuff, let's talk about how you're going to be safe. And let's talk about another thing that I think it's really important for therapists to talk about with clients is what kind of relationship, and maybe this goes to the bi-curious guy too, what kind of relationship might you like to have someday? Is it somebody that you live with? Is it somebody that you have dinner with? Is it somebody that you just have friendly sex with and then shake hands and don't see each other until the next time? Is it, are there feelings involved, or do you not want there to be feelings involved? Just having them figure out what their goals are, because often people will say, I want somebody who's going to respect me. I want somebody who's going to be kind to me. I want somebody who's going to be helpful and supportive to me. And if you start hearing those things, then you can say, wow, well, that's something you would have to probably get to know a person first, maybe before you have sex with them, if you're going to really be able to know if this person is like the kind of person you're looking for. And it just sort of helps them figure out how to take this sort of maybe vague daydream or fantasy that they have and build little step by step by step to get closer to it. I think that's the end of what I can say.
Yeah, and if there's anybody out there who works at our facilities, there's a great sign at one of our facilities, and it's in each of the bathrooms, or at least the ones that I go to. There's a condom machine in the bathroom. It's a pay machine, and on it there's a sign that says, sexual intercourse is not permitted on the grounds of the facility. However, and I'm paraphrasing again, however, we do recognize the risk of health. So should you find yourself in this situation, I'm not doing the sign justice, but we recognize that there are health concerns, and you should do this responsibly, which to me sends a message that we've got these rules that you're not supposed to have sex, but we're realistic that people do have sex, and we want you to be healthy. So, I mean, that's the message that I got from them. So, if there are any other people out there in facilities, I hope that you would follow that facility's lead and do something along those lines. I think that was a really good message, and I was very pleasantly surprised. So, with that, why don't we close down the discussion for now, and then we'll move over, because we do have one person really is interested in hearing some strategies around transgendered issues.
Okay.
And I think that's what you said.
I'm going to go fast. And people can email me if they have questions. And on the last slide of this presentation, and also if you have received the slides via email, on the last slide is a link to a really great 10-minute video that's on YouTube, which is Rainbow Heights Club members talking about their own experience of what helps and what doesn't, including transgender members. So you can either click that link, or you can go to YouTube and search for Rainbow Heights Club. Look at these amazing pictures of these amazing people. Why am I showing you these people? For one thing, they're all very different. For one thing, they're all on the transgender spectrum. And for one thing, they're showing us how much commitment they have and how important it is to them to doing what they're doing. Because sometimes we hear that somebody says, I'm transgender and I'm not comfortable with this body I was born in, and I don't think that my physical body is the real me. And we say, oh, come on, get over it. You're picking such a hard road for yourself. But all of these people are very vibrant, and they really show us what a big deal it is. The first person in the upper left-hand corner, her name is Gwen Araujo. She was assigned male at birth and had been living as a trans woman for some time. She was at a party in a small town in California, and some of her friends found out that she had not been born female, and rather than saying, oh, okay, do you want another beer, they decided that the sensible thing to do would be to kill her. So that is what they did. All trans people take on enormous risks for verbal abuse, physical abuse, discrimination, not getting hired for jobs, and frequently getting killed. In this country alone, 300 transgender people a year report acts of violence upon themselves, so you know that it's much more than that. And if you think about it worldwide, it's much worse than that. And in the United States, an average of one transgender person is killed every month. And all these people know that. And the people who come to Rainbow Heights Club and go walking down Flatbush Avenue in downtown Brooklyn looking exactly how they want to look, they know what they're taking on, but it's that important to them. Once I asked one of our trans members, how do you do that? How do you walk down Flatbush Avenue looking like that? And she said, because people were yelling verbal abuse at her, and I said, how do you put up with that? And she said, put up with what? If I walk down Flatbush Avenue looking like a lie, lying to everybody about how I really see myself, that would hurt me much worse. So that's just something to think about. The next person in your upper right-hand corner, his name is Buck Angel. He was assigned female at birth. He's obviously come a long way toward being he's a porn star, actually. And he likes to talk to the press about how he has had top surgery, that is to say breast reduction, and has not had bottom surgery. So he's sort of trying to destabilize this binary idea of gender that we have by talking about himself in the press as a man who doesn't have a penis. But again, just a very vivid and compelling person. Then in your lower left-hand corner, you've got RuPaul, a big hero and role model of mine. Even though he is very vibrant and pretty, and the reason I'm saying he is, it's my understanding that RuPaul always thinks of himself as a gay man and not a kind of woman. So this just goes to show you that there's a very broad range of motivations for people playing with or displaying different aspects of gender nonconformity. And if you think for a second about, Eddie Murphy or Tyler Perry, they've done really great work portraying female characters, but I don't think that they think of themselves as women. I think they think of themselves as entertainers. And I think that we really, their work is very powerful and appealing, but I don't think that they think they're transgender. And then the last person, that is a portrait by Catherine Opie, a famous photographer of people in the LGBT community. And she always does very collaborative portraits where she works with the person so that they are showing you what they want to show you, how they want to show it to you. And this is somebody who is showing us recent breast reduction surgery, or top surgery as it's called. And the person, I think, is kind of showing you, this is how much I care. This is how much it mattered to me to make my body closer to how I see myself. So I hope you don't find it an upsetting image. I think it's a very compelling image. So these are just pictures that hopefully will help us to unpack a lot of things that get collapsed together when we think about gender identity. Your physical body, your physical sex does not necessarily determine how you subjectively think about and experience yourself as a person. Another thing we often collapse together is sexual orientation is different from gender identity. Sexual orientation is who you are attracted to, and gender identity is how you see yourself. And those are two very different things. And overall, just to sum all that up, your physical biology does not necessarily determine who you are as a human being or how you're going to present yourself in the world. This is sort of a longer, more complicated. I have to move faster. Gender is subjectively experienced and is socially constructed. What do I mean by that? I mean that we do that. We make up gender and perform gender collectively. And gender changes and is understood differently and expressed differently in different places and times. For instance, the very butch, strong, masculine men who founded this country displayed how butch and strong and masculine they are by wearing high-heeled buckle shoes and silk stockings and powdered wigs and rouge. And I am not saying that was silly of them to do that. I'm just saying that that was the vocabulary then. There's a number of cultures that have multiple genders. In Thailand, there's a gender called lady boys, which is kind of how we might think about male to female transsexuals. And it's really not stigmatized. Your mother would not be very upset to find out that she had a lady boy in the family. And there are socially accepted roles, like taking care of the home and taking care of children and raising children. Sort of feminine caregiving roles that are accepted and are assigned to ladyboys in Thailand. So it's, but you're just, the bottom line is your subjective gender, how you see yourself, is not necessarily dictated by how your body is built. I already talked about that. Okay, some quick terms that I want to differentiate. Transgender is this very broad umbrella term for not experiencing yourself necessarily or not behaving necessarily or presenting yourself necessarily in line with whatever box the doctor checked on the day you were born. Tony, we have to stop at 2:30, right?
We can keep going for people who are willing to stay on.
Okay, well, I'm willing to stay on, but I'm trying. I tell you what, I'm gonna zoom to my final points, and then we can back up and talk more about transgender issues if people can stay. Is that all right?
Sounds good to me.
Yeah, I can go back and address this. One quick point I want to make about this is that some people progress through changing their clothes, their makeup, the way they use their voice, the way they use their bodies. Some people modify their bodies using hormones or surgeries, and some people don't do any of those things, don't change their bodies at all, and are still very successful and accepted in their chosen gender role. The people who I think are the most successful at Rainbow Heights Club in their self-presentation haven't done anything to change their bodies. So sometimes we get stuck on the idea that we have to get our bodies modified or we can't be the person that we want to be, and that is really not true. Okay, I have a final word for care providers out there, and I have a final word for consumers and families out there, and then, like I say, if people can stay on the line, I'd be happy to keep talking about trans issues and taking more questions. My final word to care providers is, you've heard my whole speech today, and you might go home, and in your heart of hearts, you might say to yourself, do I want to be the kind of care provider who affirms and endorses the right of all of his or her clients to explore their sexuality and their gender identity exactly how they see fit? And your heart might say, no, I don't. No, I don't want to do that. Well, it would be much better to admit that to yourself and admit that to your supervisor. And if you have an LGBT client and you're not comfortable working with them, you can say, you know what? I hear all the stuff that you want to work on. My colleague Frank is really skillful with working with clients that want to address those issues. Would you like to meet him and see if you'd like to work with him? That way, you have laid the groundwork for an ethical, helpful referral without bothering the client with whatever baggage or obstacles it is that are in your way, because the client should not have to hear about that. That's your stuff. That shouldn't have to be their stuff. Secondly, it means that you need to have a colleague in your clinic who you know you can turn to for LGBT effective care. And maybe some of your callers who are wondering how you can help in your own clinics, one way to start would be to let your colleagues know you don't necessarily have to disclose, I'm LGBT and I would like to treat LGBT clients, but you could say, hey, I attended this training today. I'd be excited about trying to help clients address their sexuality issues. If you have a client and maybe they want to do that and maybe you don't feel super comfortable with it, do you want to think about referring them to me? I'd be happy to do that. That would be a really great way to offer a resource in your own clinic setting and probably improve care. But again, we all want to believe that we're superheroes, and we're not. We've all got limitations. We've all got kinds of clients and kinds of diagnoses that we're not the right person to help with. And if we can just admit that and then help our clients get the care they do need, then everybody's going to be better off. My final word for consumers and family members out there, thank you for being here. You deserve quality care. You deserve therapists and psychiatrists who are going to be comfortable with you and support you and listen to you. The single determining factor of whether therapy works or not is whether the client is comfortable with the therapist. How long does it take to know if you're comfortable with somebody? I think it takes about 20 seconds. So I've talked to a lot of clients who say, oh, this therapist, I'm not really comfortable with him, but I think it's my fault, and I'm trying, and maybe it'll get better. And then I say, how long has this been going on? And they say 2 years. I'm like, stop it. If you're not comfortable with somebody for whatever reason, you deserve to ask for a different therapist. If I were your therapist and you said, I'm not comfortable working with you, I'd rather work with somebody else, I would say, thank you, because now we will not waste each other's time. So I really feel that way. Any competent therapist is not going to take it personally, and you deserve to say, can you help me? If you don't want to help me and affirm me, I'd like you to refer me to somebody who can. And if you're not able or willing to do that, I'd like to speak to the director of the clinic. I just, I want you to know, a lot of people don't know that they're allowed to say that, but you certainly are. Here's my contact information. Here's the YouTube link. And if you can't stay longer, I understand, and I thank you for being here.
Thanks, Christian. Before people leave, I do want to let them know that there will be a window that pops up. If you leave early, you won't get the window, but you can always send an email to me about in regards to if there were other people there who need a certificate. Next month's webinar will be on parents with psych disabilities. That will be on October 28th, Thursday, October 28th from 1 to 2:30. That's parents with psych disabilities. Lorraine McMullen from Mahaney's will be doing that. That's the Mental Health Association of New York State. You can go to their website, and they've got a lot of good information there. I'm sorry I don't have the link available at this point to register, but we will be sending that out. Also, as Christian was speaking earlier about, there are some people who are not interested in having a relationship. I was one of those people, and I met somebody else who was not interested in having a relationship, and then we got married. So sometimes you don't have any control over those things. And we are looking for panelists to be on a webinar for next year to talk about love and relationships and how important that is to recovery. To be loved and to be lovable and to give love is something that is the philosophers and poets have been writing about it for since the dawn of time. So it's something that's very important, and a lot of times we don't talk about that in the mental health community. So that's a subject that we really want to talk about, and if anyone has any personal stories that they would like to share and join with us on a panel, that would be great. That's something new that we'll be trying as a panel discussion. And with that, let's go back to some questions. Basically, the main theme of the questions that are coming, Christian, are around creating a safe, welcoming environment for people in the LGBT community at their clinic to help train staff. It sounds like there's, well, and maybe we're preaching to the converted, but it sounds like there are some people who are really wanting to make their clinics and their environments more welcoming and make their staff more, help their staff understand to be more sensitive and empathic.
And how to do that?
Yeah, any strategies on that?
Well, for one thing, my colleagues in our parent clinic, Heights Hill Mental Health Service, are going to be doing a webinar for OMH, for another division of OMH, I think the Bureau of Cultural Competency, on October 21 at 10:30, and they're going to talk specifically about how they developed an LGBT affirmative treatment program within the clinic and then spun off Rainbow Heights Club, because they trained the whole staff in how to be more effective with LGBT clients, and then they started getting clients from all 5 boroughs of New York City. So You might want to, if you have a small working group of people who want to address this issue and want to read some, maybe bring in a couple of speakers to educate people about LGBT issues and treatment issues. That way you're not demanding that the whole staff get on board. But I think it would be hard, especially if you're willing to do it, I don't know, with a minimum of resources. It would be hard for the staff as a whole or for the chief administrator to say, I refuse to allow you to develop the means to serve a needy, overlooked, underserved subpopulation. I don't know. I mean, if there's people who are willing to do the work, then they might be sort of like the yeast in the bread. And what my hope is because I've done a lot of trainings of staff, and what my hope is that, because there's always a range of people on a given staff, people who are very engaged with wanting to take on these challenges and meet the needs of a specific population, and people who are more reluctant. And that can be okay. That's just reality. But I think if people start to hear more in staff meetings and rounds and clinical case discussions about greater successes that clinicians are having when they have a little bit better toolkit, a little bit better effectiveness with LGBT clients, then it's sort of inspiring. And you also kind of realize that it's not so different from just the clinical issues that we all deal with, just like we were talking about letting the client define their own goals. That's an overarching theme that has a lot of power and resonance. And secondly, if there's a handful of people on that staff who are good at working with those clients, then that gives everybody else somebody to refer them to, which is very helpful and reduces people's anxiety level. Because if you are, A, uncomfortable with working with these issues, and B, you don't have anybody to refer that client to, then you're kind of stuck sitting there feeling miserable week after week. And, if you had somebody to say, oh, hey, could you, I think I have a good client for you, then everybody's kind of more comfortable. And I think gradually even people who are reluctant or uncomfortable, it's just sort of, they start to shift over time just through exposure. That's just some thoughts off the top of my head. But
those are great strategies.
Find out. Huh?
Those are great strategies.
Okay.
Yeah.
Next. Or do you want me to go back and talk about trans stuff?
Yeah, it looks like I haven't had any new questions come in. Oh, wait a minute. Now, just as I said, that one came in. So let me throw this out. I have a teenage client who has extensive trauma history and is transgender. I am treating her with affirmation, but are there specific treatment recommendations for and ethical considerations of a client with trauma who is expressing transgender identity? And we hadn't really touched too much on trauma, and that's always a big issue with the mental health folks.
What was the last part?
No, I was just giving them. We haven't really talked much about trauma.
Yeah.
In this today.
Well, again, I want to give my proviso that working with youth is outside of my expertise, but a mantra that I have is you can take your time and find your own way. You can take your time and find your own way. I think a lot of people sometimes have an imaginary or ideal self that they wish that they could embody immediately. And if they could embody that ideal self, maybe it's their preferred gender role, maybe it's, some kind of version of a superhero, then everything will be okay. And if they can't embody and show the world and have the world accept that preferred version of themselves, then it's a disaster. And my mantra is sort of like trying to work against that and say, you are unfolding. You're blossoming, and just like you can't take a rose that's like in the form of a bud right now and you can't just peel it open, you have to let it open up in its own time, petal after petal, gradually. Just so you are developing now, and even if the world doesn't necessarily understand you, even if a lot of people in your life don't even know what your preferred gender role is, I can give you that acceptance and that support here. And little by little, as you grow and as you find your way, you're going to figure out who you're going to become as an adult. But that's a gradual process, and it takes a long time. And I want you to have your safety, first of all. I want you to have your safety in school. I want you to have your safety in your family. Can we explore gradually whether your family is going to be supportive of you? And if they're not, then maybe we should work on things that you can do after you're no longer living with them. Because a lot of families really struggle with sexual orientation issues, and particularly transgender, gender identity, gender expression issues, if they're still supporting the kid. But if a kid is living on their own, sometimes that's a lot easier for parents to deal with. It's like, well, it's your life now. So I'm not saying that somebody should run away at the age of 14. I'm saying that somebody should keep their safety and develop social support and make it until they're 18 or 21 or they're ready to move out on their own, and then explore these things in a responsible, careful, deliberate way. I don't know. That was a long speech based on very little information. I hope it was helpful. It could have possibly completely missed the reality of the situation you were trying to tell me about.
No, I don't think so. But what I do think is that what it seems like is that there's a lot of confusion about some specific, how to engage with some specific clients, and that's probably not that's probably a general thing across the state and not just for the people here. I'm wondering, is there a place where people can go to consult around this? I mean, what is the ongoing sort of education beyond like a webinar like this? I mean, I know OMH has a cultural competent, or yeah, we have a Bureau of Cultural Competence that people can certainly use, and you can call here. I'm not sure exactly what that number is, but if you call the general number, you can get to the Bureau of Cultural Competence here, and they might be able to guide you. But do you know of any other places where, I don't know, I'm thinking now more providers, where providers can go to get some specific advice, more on a one-on-one thing?
Well, I mean, there's a lot of some websites and a lot of books about how to do LGBT affirming psychotherapy, group psychotherapy. There's a lot of resources around that. Also, SAMHSA, the Substance Abuse and Mental Health, they have a curriculum that I think you can have for the asking, which is a folder and a CD-ROM and probably a PowerPoint about how to provide LGBT-affirming care. Mm-hmm. So that's a curriculum and materials that are available if you want to request them for your clinic. Also, I would recommend, while you're calling the Bureau of Cultural Competency, ask them how you can sign up for this webinar. Actually, with the materials, we could forward you information about the webinar about how Heights Hill Mental Health Service developed its LGBT program. And I do just want to add, any underserved population that you can identify, if you can build services that will meet their needs, and if they bring Medicaid dollars with them, you can form, a clinic that affirms those needs. Maybe it's like recent immigrants, maybe it's, I don't know. So, but you could also not only take it as a LGBT service development, but also any underserved population. How can you develop services that meet their needs? I have now completely forgotten the question that I was supposed to be answering.
I think we were just talking about in general, and if there was a specific place
ongoing.
To go to.
I currently I'm seeking some grants to support us doing trainings like this, where we go to an agency and train the entire staff of an agency. We also have presentations that we've done for all the consumers in a mainstream day treatment program. It's very powerful. Usually consumers are more progressive than staff. And everybody's usually stunned when we have these conversations, and people say, no, it's okay. I don't mind supporting LGBT people here. I just would like us to have a rule that nobody's going to hit on anybody here, and then we'll all feel safe, and then we'll all have the safety and support that we need, which I think is a completely reasonable rule. But sometimes it's easier for me to come in as an outsider than it is for the staff of a residence or an agency to have that conversation with their clients. But like I say, I'm trying to get support for that. I am not aware of ongoing training resources for LGBT cultural competency.
Well, I think in some ways it's not a bad idea to go back to basics, look at things like motivational interviewing. A lot of what you were describing today, I could easily relate to, through my mental health problems. So I mean, it was like, yeah, I mean, just pluck out LGBT and put in, the diagnosis, and it was all very reasonable, and it sounded like strategies that could be used, that could be transferred from, that people don't have to make a big leap from, the strategies that you would use in good person-centered, recovery-oriented care to, a person with LGBT or in the LGBT community. It doesn't sound like that's a big leap in logic, and that just going back to the fundamentals. And we hear a lot of specific examples all the time, and sometimes the mantra that I use for myself is just, you can't go wrong if you listen to people. Just be quiet and listen. Be honest with people, and if you don't know what to do, that's okay to say that. It's okay to be honest, and be respectful. You really can't go wrong, I think, with following those three things, and then just over time things will unfold as however they're supposed to. So
those are great mantras, and I really believe that they're applicable. You reminded me of something I meant to say. I think one other obstacle that sometimes consumers and providers run into in doing this thing of like consumer-oriented care and self-defined goals is we don't have a lot of healthy images of gay and lesbian and bisexual transgendered people thriving, having their mental health, having intimacy, having healthy relationships. We just don't have a lot of images like that in our minds because our culture hasn't given us enough images. Even though there are lots of people out there doing all those things, we don't necessarily have mental pictures of them. So if a client says to you, a male client says, I would like you to help me find a boyfriend and settle down, you don't have this big database of happy pictures that you can pull up and say, aha, yes, of course we can do that. Lots of people have done that. I can help you do that. So I think just that lack of mental images, positive mental images, is an obstacle. But I absolutely agree with you. Just putting one foot in front of the other and listening, and if you know how to help, do it. And if you say, boy, I don't know what our next step is, but I want to support you, then that's good too.
Okay, well, I think we should wrap up. There was someone who sent in the information for the webinar that you were discussing on October 21st. So I'll gather that information up, and we'll send that out to everyone who registered today to make sure that you all have that.
That's great.
So thanks, Christian. This was really great. I love it when we go over time a little bit, and we had a great discussion, and I hope folks got a lot out of it. I know I did. Thank you very much, Christian.
It was a wonderful experience to be here, and thank you all, and thank you, Tony, for making this possible.
Thanks. Now, we did record this, and we will be sending the link out to folks in a follow-up email, so you can share this with folks as you see fit.
Okay, thank you.
Bye-bye, everyone.
Bye. Bye.